discussion will be for the use of hormonal therapy for menopause. Is it effective? In this presentation, I will discuss the current approaches to manage menopausal symptoms and menopausal treatment. This shows the stages of reproductive aging in women. As we know that as the age passes, the reproductive capability of the women changes. This is the 10th stage criteria, and the initiating point is the final menopausal period, which is the 0 stage, and the stages before these are in label as minus, and after the past menopausal period, the stages are +1. These stages are shows the ovarian aging and the capability of the women to reproduce. So this stages of reproductive aging in patient will tell us about the assessment for fertility, contraceptive needs, and healthcare decision making. So this criteria is very important, and this includes the biochemical changes in the form of changes fluctuating levels of hormone, that is the FSH and AMH, and also the menstrual cycles. Signs and symptoms during and after the menopausal transition. The symptoms and signs usually start after the age of 40s and last till the end of life of the woman. Initially, the initial phases from 40 to 60 years of age, the vasomotor symptoms are common, and then they can arise after the age of 40 and may last till the age of 60. These vasomotor symptoms are hot flashes, sleep disturbances, mood changes, etc. Then the menstrual disorders also occur during this years, that is after 40 years, at 45 to 50 years of age, or even 52 years of age, the women may face problem with the menstrual cycles. As the age passes, the changes in the epithelium results in the problem of urogenital system, resulting in dyspareunia, dysuria, frequency of urinary symptoms, and skin atrophy. During the last years of age, that is extending from after 50 years till the end of the life, the chronic problems like osteoporosis and also the metabolic problem like atherosclerosis, coronary heart disease, and cerebrovascular disease are more common. Worldwide, the most women experience their final menstrual period between the age of 45 and 55 years of age. Late onset menopause is labeled after the 55 years of age. It means that if the women experience menopause, last onset of menopause, that will be 55 years of age. The early menopause is between 40 to 45 years. Premature ovarian insufficiency occur before the age of 40 years. Then there are some conditions which are iatrogenic, like surgical removal of the uterus or post-radiation or use of drugs, which can lead to menopause. Surgical menopause happens when both ovaries are removed before the natural switching of ovarian hormones. The earliest symptoms, as has been discussed already, they are in the form of hot flashes, sweats, mood swings, disturbed sleep, migraine, and poor cognitive performance. And they usually start before the final, usually start few years before the final menopause and may last till many years of menopause. The late onset manifestations are the central fat distribution, metabolic and cardiovascular consequences, urogenital atrophy and sexual dysfunction, osteoporosis, and increased risk of disabling fractures are the late complications of menopause. Two major well-published studies, that is the WHI, the Women's Health Initiative, which was done by USA from 1993 to 1993 to 2004, and the Million Women study that was done by UK and NHS from 1996 to 2001. They have shaken the These studies have shaken the faith in the safety of HRT for doctors and postmenopausal patients. The WHI study consisted of two groups. One group was the patient with intact uterus, and the second group was hysterectomized patients. Both groups were divided into two groups further, where one group was given the medicine and the other was given the placebo. In the intact uterus, the estrogen and progesterone combination was used, and in hysterectomized patient, the estrogen alone was used. And it was intended to follow for 8.5 years. The aim was to see that whether the women have the use of hormones results into cardiovascular accidents and the breast cancer or not. Estrogen and progesterone wing has to be stopped in 2002 due to increased incidence of heart attack and breast cancer. Estrogen wing has also to be stopped in 2004 due to increased incidence of stroke. So there was flaws or faults in WHI study, which was initially observed, and then later sub-analysis showed the results were different. There was no individualization, with the presumption that one dose of Prem-Pro fitted all the patients regardless of age and general health. The study design did not bother to acknowledge the different women required different dose by different routes of different combination of different hormones for different symptoms. The average age of women was 63 years, range between 50 to 79 years, and 22% being over the age of 70 with an excess of obesity, hypertension, and pre-existing cardiovascular disease leading to prothrombotic problem. Later sub-analysis of the data in 2003 showed that the excess of cardiovascular events occur only in the women starting estrogen and progesterone 20 years after menopause. That is, these hormones were started after the 20 years of menopause, the incidence of the cardiovascular events were high in those women. 97% of the patient in normal clinical practice who benefit from HRT is usually less than 60 years. It means that if the hormone start before the 60 years age, that is the range between after the menopause till 10 years. This is the first 10 years of the life where a patient can get benefit from the hormone replacement therapy. Later sub-analysis of the data also showed that estrogen only showed that in 50 to 59 years old age there was 42% decrease in the coronary heart disease, 28% decrease in the breast cancer, 27% decrease in the deaths, and 20% decrease in the global index pathology. So women in younger cohort has a trend towards improvement of cardiovascular risk and significant reduction in all-cause mortality. In the past, there has been much confusion about the menopause and treatment options. Clarity was needed, and now it has been provided approved. While treating this problem in menopause, we come across the following questions. Who is MHT for? Then what types and doses of MHT should be used? When MHT should be started and stopped? Should a woman without symptom be prescribed MHT? How to measure the risk and benefits? What are the side effects? What about the special conditions like CA breast, endometriosis, carcinoma, endometrium? And what about the early menopause like premature ovarian insufficiency or surgical menopause? The factors that determine the type and dose of MHT include the following: patient preference, uterine presence or absence, contraceptive needs, symptoms and severity of the symptoms, and comorbidity. Management options which are available for these patients are lifestyle modification, exercise and diet, cognitive behavioral therapy, self-help tips and coping strategies, medical therapy, and MHT. The hormones on the treatment which are available for the use of menopausal problems are estrogen, progesterone, combined estrogen, progesterone, uh, Tibolone, antidepressant, and clonidine. Lifestyle modifications are very important because this help in the maintenance of the good health, physical and the mental health. The regular exercise is advised to reduce the cardiovascular and effects and total mortality. Weight loss about 5 to 10% is sufficient to improve many symptoms. Then smoking should be avoided. Healthy diet in the form of Mediterranean diet in the form of vegetables, fruits, nuts, legumes, and especially the fatty fish are very important for the maintenance of good health. Salt and alcohol consumption should be limited. The women should wear loose clothes and sleep in a cool, well ventilated room if she experiences hot flashes. Then cutting down the coffee, alcohol, and spiced food as they have been known to trigger hot flashes. When is it necessary to start with the HRT or MHT? It depends upon many factors and it should be personalized treatment based on chronological and menopausal age, patient history, physical characteristics, uterus absent or present, previous treatment, current health status, past medical history, family history, individual preference and concern. Counseling is the most important part of the management of these patients and before as in prescribing the hormone therapy, all aspects of the women health should be discussed. It must include assessment of the patient's symptoms, needs, desires, and risk profile to address the benefit and risk of menopausal hormone therapy on an individual basis and promote a culture of involving the patient in making decision. Indication for HRT and benefits. What are the indications? The proven benefits are control of menopausal symptoms, maintenance of BMD, and reduce the chances of having osteoporotic fractures and maintains quality of life in menopausal years. Additional benefits are the HRT and MHT reduce the risk of coronary heart disease, reduced risk of Alzheimer's disease when estrogen started early, reduced risk of colorectal cancer, and reduced risk of type 2 diabetes mellitus. The estrogen has a very benefit effect on the cardiovascular system because its presence reduces the atherosclerosis due to raise high density lipoprotein, protect the endothelial function, dilates and relaxes the blood vessels, and lowers the total cholesterol and low density lipoproteins. Contraindicated indications to menopausal hormonal therapy are personal history of breast cancer, severe active liver disease, coronary heart disease, stroke, and venous thromboembolism. These contraindications do not apply to transvaginal based estrogen therapies as transvaginal transdermal therapy as serum concentration of estrogen from this route is very low. Known risk of this hormone therapy are the endometrial cancer. Endometrial cancer usually occur if it is given unopposed. Estrogen is given unopposed from the progesterone. There are chances of having endometrial carcinoma. And reduction by addition of progesterone, continuous progesterone provides better long-term protection than cyclical. DVT and pulmonary thromboembolism, 2 to 3 2 to 3% background risk is there, which is 1.5 per thousand women age over 50. Greatest risk is the first 12 months of the treatment, probably less than oral. Does it non-oral? It means that if the if the preparations are given in the form of patch or gel or vaginal cream, there the chances of development of DVT are very less. Then coronary heart disease increases when combined HRT start It starts in older age, that is, or with pre-existing cardiovascular disease. This cardiovascular window of opportunity started within first 10 years after menopause. Probably, breast cancer probably increased slightly after the minimum of 5 years use of combined HRT over the age of 50. Additional 3 to 4 cases per thousand women are there. Risk associated with estrogen alone is very much less. Mortality is not increased. Then, what are different preparations of hormones? The hormones for replacement therapy are in the form of estrogen, progesterone, and testosterone. Estrogens are most commonly prescribed and normally compounded with progesterone. Progesterone, commonly prescribed hormone, often prescribed along with estrogen. Testosterone rarely advised women, recommended to combine with estrogen and or progesterone. The estrogen which are available in the market are in the form of oral and or transdermal or transvaginal preparation. The conjugated equine estrogen available, and it was previously available in the strength of 0.625, but after the WHI trial, the dose has been low dose has been recommended and now available in zero point 0.3 milligram percent. Then micronized 17 beta estradiol is available. Estradiol valerate in preparation available in 1 milligram and 2 milligram, and transdermal, that is 17 beta estradiol, available in the market. Then the progestogen which are available in the market are progesterone, dihydrogesterone, drospirenone, and methoxyprogesterone acetate, and norethindrone. They can be used alone, or they can be used in combination with the estrogen. So in summary, the estrogen available are in the market are in the name of Progainova, which is estradiol valerate, is available in Pakistan, is available in 2 milligram strength, and the Primarine in the form of conjugate estrogen are available in 0.625 or 0.3 milligram strength tablets. Combined estrogen progesterones which are available in the market are Trimin and Progesterone. Famastone was previously available in the Pakistan, but now it has been withdrawn from the market, and the only available combined preparations are Trimin, which is the estradiol valerate 2 milligram, and cyproterone acetate 1 milligram, and progylitone estradiol valerate plus progesterone. There are certain different conditions where the hormone therapy are used. The common menopausal symptoms in the form of hot flashes, night sweats, insomnia. In these patients, if the patient is healthy and the weight is normal, the woman that is approximately early menopause, mean that 5 to 7 years from final menopause period, oral estrogen or transdermal estrogen at maximum doses combined with cyclic or continuous progesterone can be given. Tibolone can be given at low to standard doses. Tissue selective estrogen complex at the standard dose. Now, in healthy late menopausal women, mean after the final menopause of 8 years, the MHG may be continued but seldom begun with the following regime: low dose of transdermal estradiol or low dose of oral estrogen associated with micronized progesterone or isomer dihydrogesterone administered continuously, or low dose tibolone can be used. In overweight women, that is the body mass index more than 25 kg per meter square, and early menopause women, that is approximately 5 to 8 years from final menstrual period, the following regime is generally suitable: transdermal estrogens or combined with cyclic or continuous progesterone. In women with where the ovaries have been removed, that is the surgical menopause, if the uterus is intact, then medium to high doses of oral estrogen or transdermal estrogen in combination with approximate doses of progestogen where needed. Transcutaneous testosterone therapy may be necessary when hypoactive sexual disorder is diagnosed, and that is at the dose that achieve the normal premenstrual range of circulating testosterone levels. In women with primary ovarian insufficiency needing contraception, the following regimes are generally suitable for first few years after diagnosis: low-dose estrogen progesterone contraceptives or estrogen associated with the levonorgestrel intrauterine system. There's another very important condition which is called the pure female gonadal dysgenesis. Here there is the chromosomes are 46 XX, and it's a primary ovarian failure defect leading to premature ovarian failure in otherwise normal female as a result of failure of gonad to develop or due to resistance of gonadotrophin stimulation. The types of hormone replacement therapy in these patients are early in the first estrogen therapy started, that is in the form of oral transdermal patches gels. Common agents are estradiol or conjugated estrogen. Benefits are symptom relief, bone health preservation, and other reduction of other cardiovascular complication. Then in the first few months of only the estrogen therapy is given, and then estrogen is combined with progesterone therapy, and the commonest progesterone therapy are progesterone, norethindrone, medroxyprogesterone acetate. Dosing is either given cyclic or continuous with the vitamin D and calcium supplementation. So this should be till the age of menopause, and this therapy will reduce the chances of causes the development of the secondary sexual characteristics and prevent the osteoporosis, and also prevent the cardiovascular accidents in these women. Self help tips: coping with strategies: avoid sudden temperature change, reducing caffeine, alcohol, avoiding spicy foods, increase exercise, then practice relaxation techniques using cooling devices like the facial spray and or cold pillows, etc. Wearing absorptive night tire, long-term trials of alternate over the counter treatments. Then sexuality is also affected by the menopausal period, and then the most common disorders are either there is dyspareunia or there are sexual hypoactive disorders. In the early post-menopause, transdermal estradiol-based treatment significantly improve overall female sexual function, whereas oral conjugated equine estrogen-based treatment has less effect. Tibolol is the most effective therapy for restoring sexual function, including desire, sexual interest, and satisfaction, which may be attributed to its combined estrogenic and androgenic properties. In women who develop hypoactive sexual desire disorder, transdermal testosterone treatment can be used to restore sexual function. Dihydroambiandrosterone is also available in the oral form, and oral supplementation may be used in women with low sex desire, and there is low sex derived associated with low levels of circulating dihydroambiandrosterone. Prasterone is also available in the Western country as a vaginal tablet, that is a vaginal dihydroambiandrosterone. This can be used in the symptoms of the sexual disorders. Genitourinary symptoms are in the form of vulvogenital atrophy, such as dryness, dyspareunia, itching or burning, dysuria, urinary frequency, urgency, recurrent lower urinary tract infection. The preparations which are usually used are the local preparation, and they are very effective because they have got local effect, and these are not absorbed in much concentration in the blood, and these do not have any worse effect in the body. Vaginal estrogen therapy is the first line treatment and more effective for symptoms than systemic estrogen therapy. Women on systemic therapy to relieve their symptoms of menopause will be benefited from a significant reduction in the vulvovaginal atrophy. Moreover, it may be used alone, in which case there is no need for endometrial protection or in association with systemic MHT. So, vaginal preparations are available in the form of vaginal tablets, vaginal ring, vaginal creams, and gel. These preparation may help in reducing the menopausal symptoms as well as local effect in the vulvovaginal atrophy. Then, for how long systemic HRT or MHT can be used? That is, the indications are symptoms control. The symptoms duration of treatment as long as it is felt that the benefits of symptom control and improvement in the quality of life. Any risks? There are no arbitrary limits for the use of MHT in the controlling of symptoms. Treatment of premature ovarian insufficiency. At least the duration of treatment should be at least until the age of menopause, that is menopause may be 50 or 51 years of age. Prevention and treatment of osteoporosis. Therapy for several years may be required, followed by consideration of use of other bone protective therapy. Then follow-up and review is commence on HRT change 3 months. That is, after 3 months, the first review is done. After 3 months, in this review, the side effect or the improvement with the HRT are inquired, and then it is advised to have, if everything is all right, patient symptoms are improved, doses adjusted, then it is advised to have a review or checkup follow at least annually. Each review should assess the effectiveness and side effects of therapy, discuss any bleeding pattern, review type and dose, help assess ongoing risk and benefit balance. Then question arises, does HRT increase breast cancer risk? Questions. Is there any risk? What is the risk if the patient has a history of CA breast? What is the risk if the woman has family history of CA breast? What is the risk if the family history is there and she is BRCA1 positive? So in these conditions, there's evidence that if the patient is having herself risk, it's a contraindication to use the HRT. But if the patient is having family history, is there is the family history of breast cancer, or the patient has a family history of breast cancer and she's herself BRCA1 positive, considering the risk benefit, the HRT can be administered in these patients after proper counseling and considering their needs of symptoms. Alternate options for menopause are antidepressant, clonidine, isoflavones, black cohosh. St. John's wort can be given in the appropriate doses, and it may be benefit in relief of vasomotor symptoms. There is uncertainty about the appropriate doses, persistent effect, variation, the nature and potency of preparations. This is the flow chart showing the administration of the estrogen and progesterone proportion. This is the summary of the hormonal administration in the patient. If the patient is, we know that if the patient is hysterectomized or by nasal situ, if the patient is hysterectomized, then estrogen only is given either in the form of oral estradiol, conjugate equine estrogen, or transdermal estradiol, that is in the form of gel and patch. If the patient is not hysterectomized, then if that the uterus is present, then combination of estrogen and progesterone is given. In the perimenopausal stage, the sequential therapy is given because the patient is also having irregular menstruation. The sequential therapy will also improve the menstrual periods as well as the improving the symptoms. Though sequential therapy may be given in the form of oral or patch, and the postmenopausal patient continues combined period-free preparation is given in the form of oral or patch. Changing progesterone component may be required if the progesterone side effects occur. Indications for transdermal therapy are in individual preference, poor symptom control with oral GIT problem affecting the oral absorption, previous or family history of thromboembolism or BMI more than 30 or variable blood pressure control, migraine, current use of hepatic including enzyme medications, gallbladder diseases. All these are the indication where oral therapy can be bypassed by giving transdermal patches. So that is the summary which shows the administration of MHD in different conditions. In conclusion, this discussion, the oral hormone therapy is in menopause is multifaceted. HRT may effectively alleviate menopausal symptoms and improve the quality of life for many women. However, it is crucial to recognize that HRT is not without risk, and the decision to initiate or continue HRT should be individualized, taking into account factors like age, medical history, and personal preferences. As research continues to evolve, it's important for the health providers and patients to stay informed about the last evidence and guideline regarding HRT. Ultimately, shared decision making between patients and healthcare providers is essential in navigating the complex landscape of menopausal hormone therapy, ensuring that treatment decisions align with each woman's unique needs and priority. Thank you very much.